Dr. Shapiro, and we're doing the last Pimp My Pod podcast. This is number 8, and we're going to be sort of preparing for the final exam. So my plan for today is for us to focus on bone tumors, because tumors are really the hardest part of all this. The complications part's a piece of cake compared to how much you have to know and pattern recognition and all that kind of stuff. So let's get right to it. Okay, so here's my pick of the week. Hopefully something fun. If you haven't heard of this before, look this up on YouTube. So go to YouTube, type in either ortho versus anesthesia or the web address listed below, and you'll see this kind of funny interplay between an orthopedist who just wants to fix a fracture and a anesthesiologist. And there's this, sort of funny kind of approach to what an orthopedist is like. Probably very similar for podiatrists in the same way when you look at it. So go for that. It's like 3 minutes long. It won't kill you to take a few minutes and take a look at that. Maybe you'll have a little laugh. Okay, so we're going to get right to our discussion of bone tumors, and I find this to be one of the more difficult parts for us. And for some reason that nobody really knows, on most of your board exams, you're going to have bone tumors. So not your first board exam, but your second, your third, your board qualification, your board certification, they are going to have more tumors than you know what to do with. And it's odd because tumors are most commonly treated in tertiary care centers, especially when it comes to things like cancers or tumors that are destructive or require large reconstructions. But yet somehow we still have to know. And so I want to kind of talk about the way I approach these, or at least the kind of maybe sort of what all this stuff means that we've been talking about in the PMP4 class, and see if it might just at least give you a sort of a framework in which to apply in the real world outside of class. We've already gone over what the final examination is going to cover, so this is really more extra. I hope to provide as many images as I can so that you can start to get the picture of what some of these tumors look like, especially the more common ones. So let's get to it. Okay, so this is my approach. It's really kind of simple. I look at the age, the number of lesions, the appearance, and the location. Now, of course, within each thing, there's a little bit more detail for that, so we'll go through that. So the age is age of the patient. The number is if it's really a single or a monostotic lesion, or if it's multiple or a polyostotic lesion. The appearance is going to really include a sort of a large number of things, and really is the bulk of what we're going to talk about. And then the location will give you extra hints, because certain tumors show up in certain locations because of the type of tumor that they are, and this will give you extra information to at least create a reasonable differential diagnosis, and then to be able to direct your care for the patient. Okay, so here's age. So if you were to break this down into less than 20, which is, think of it as like kids, young people, 20 to 40, or greater than 40, or the, kind of the elderly, I suppose. For somebody who's 48 years old, to call myself elderly is kind of weird. But if you look at this, you have benign and malignant lesions. Luckily, there are more benign than malignant lesions on this list. The list here is not complete, not totally complete. There's a lot of bone tumors of really every kind of cell in the body, but we're looking at the main ones that we have to concern ourselves with. Now, if you look at this, the under 20 have the largest number of tumors. So instead of memorizing everything on this list, look at the other ones. Look at the 20 to 40. So benign, you only have 2 lesions, 2 bone tumors that are benign in 20 to 40-year-olds, enchondromas and giant cell tumors. And then with the malignant, you have one, Paraostial Osteosarcoma. Okay, and then if you look at the greater than 40, you can see that they're really a small number. Again, there's only two in the benign, intraosseous lipoma and hemangioma. And then in the malignant, you have metastases, myeloma, and chondrosarcoma. So if instead of memorizing all of these, just look at the ones that are 20 to 40 and remember what's benign and malignant. Look at what's greater than 40 and know what's benign and malignant, and then just think everything else is going to be under 20 or young people. So think about it that way. Okay, so that's age. Very simple, kind of straight memorization. All right, now let's look at single versus multiple lesions. Now, any lesion that you have can come as a single lesion. Not all of them are going to come as multiple lesions, though. So instead of memorizing, again, everything for single lesions, take a look at this list. This is, one sort of maybe crappy mnemonic, feme he, feme high, in order to remember which ones can show up as multiple lesions. So you can see this list: fibrous dysplasia, eosinophilic granuloma, enchondroma, metastases, myeloma, hyperparathyroidism. These are Brown's tumors, which do show up in the foot, and infection. Now, the other thing about this is if you're creating a differential diagnosis, just about every tumor in the older than 40 age group is going to include metastases and myeloma. But really, eosinophilic granuloma and infection can also be seen in just about every tumor that you can think of. So eosinophilic granuloma is going to look a lot like anything, and infection will look like just about anything. Now, luckily, in the case of the foot and ankle, infections is, remember, we're talking about osteomyelitis is the infection we're talking about. That infection is always going to be associated with an open lesion. So that one's going to be an easier diagnosis for you to make, and that one almost doesn't even come into the realm of bone tumors for podiatrists. So if you have to include something, then eosinophilic granuloma and infection is just about everybody, and metastases and myeloma for the elderly population. And then again, feme high for any multiple lesion. Again, remembering that everything can show up as a single lesion. So, okay, now let's talk about the appearance. This was the third and sort of larger thing that we were going to talk about, and this is really going to tell you a lot of the information that you're going to use to make decisions for your patients. So we're going to look at the destructive pattern, the zone of transition, the involvement of cortex and periosteum, and then in some cases the pattern of the matrix or the space or the material inside the tumor itself. So let's start with the destructive pattern. I know we've talked about this in class again, but I think it's worth us looking at these with a few examples as well. So here's an example of a geographic lesion, remembering that geographic is generally going to equate with benign. So here's your geographic lesion, and you can see that this has a sclerotic plantar aspect to it, and the more distal aspect is sclerotic, which is going to tell you that it's much slower growing. Then if you look on the dorsal side, it's got a little bit of sclerotic part to that, but then on the more posterior aspect of that, it is we lose that sclerosis. So we might consider that to be maybe a potentially slightly faster growing area. Now we know it's geographic also because if you could take a pencil or your finger and outline exactly where the lesion is and where it ends, and that's what really is going to make this a geographic lesion, again, more likely to be benign. Now, on the other hand, this is the destructive pattern that we call moth-eaten. And remember that moth-eaten is multiple small relatively well demarcated lesions in an area. And you can see in this osteosarcoma that uh, there are these multiple, pretty well circumscribed lesions that you can kind of pick out, and there are a whole bunch of them. And then you can also happen to see the pathologic fracture of the humerus in this particular case. Now, in some cases, they're moth-eaten, and the other version, which is worse than this, are permeative, are going to be together at the same time, and we'll look at that in a minute. So here's our other one. This is the permeative destructive pattern. And if you look at this, some of the lesions in this bone are relatively easy for you to demarcate. You could outline them to some extent. But when you look at the whole thing, you can see that it kind of blends out. In many cases, it's really hard to know exactly where the lesion begins and where it ends. So this is considered a permeative pattern, which is a worse, much more likely to be malignant, destructive pattern of bone. So remember, the geographic tells you that it was probably benign, it's relatively slow growing. The moth-eaten and permeative are more likely malignant and probably faster growing as well. Okay, so this is an example of where you might see a moth-eaten and permeative pattern together. And in fact, most of the time, these are commonly combined, and you see them both together at the same time. And that's really what we tend to see more commonly. So the part that you could demarcate relatively well would be that moth-eaten, and then the interstices, or the spaces between them, are probably the permeative pattern. So you can see that in this fibrosarcoma of the calcaneus. You can see areas where the thin arrows are permeative, very hard to see sort of where the normal calcaneus is and where the abnormal is. And then you can see, like, with those kind of fat, especially on the plantar tubercle, you can see the sort of fat arrow. And you can see that that is a moth-eaten, very well sort of demarcated lesion. So fibrosarcoma, bad situation for this patient. Okay, so also, I mentioned about the circumference, or the perimeter of the lesion. So the next part of this is really to look at the zone of transition, and the zone of transition is going to tell you really about how fast this lesion is growing and how invasive it is. So you look at the border of the lesion, and you look at this and you think, is there a rim to this? So I wouldn't worry about the 1A, 1B, 1C part of things. This just comes from a classic article that describes different types of, the different aspects of lesions. So if you look at the top left, you can see that that is a well-demarcated geographic single lesion, or monostotic lesion. So I could draw a line around that really easily, and it has a sclerotic rim. So that's telling you that well-defined rim means that it's very slow growing enough that the bone can build around the tumor. Then if you look to the middle top one, you can see that the destructive pattern is now pretty well, it's well defined, but it no longer has a sclerosis. So it's moving a little faster, it's growing a little quicker, and so the lesion, the bone around it, the normal bone, is not able to put down bone enough. And then the top right shows an even faster growing lesion, where now you see that it is still well defined. You can still kind of see where the lesion is, but the margin is much less defined than previously. And that's telling you that's moving even a little faster than before. The other one that I would suggest that you take a look at is really about the bottom middle image. The other two are less important for our circumstances, but really what you've got there is a pattern that the lesion has broken out of the cortex entirely. And that is, it's going to start invading the soft tissue at that point. So that's a little bit more concerning as well. Okay, so zone of transition is telling me really how aggressive or how fast this lesion is moving. So here are a couple of examples of different ones. You have this on the left. You have this well demarcated lesion. This is the one I showed you before, where you can kind of see the sclerotic rim, at least to maybe half of it. It is this slow growing. Then the lesion in the middle, you can still see it, but it doesn't really have, it has this sort of like a blended out cortical rim, and that, that's that sclerotic area. It's not a well defined area of sclerosis, so it's growing enough that it can have some bone deposition around it, but it sort of blends out. So that's a little bit more rapid. And then the one on the the right, is you can see, again, it's well defined. You could tell where it ends and pretty much where the normal bone begins, but it doesn't have really any margin that you can see. So there's no sclerosis. It's really ill defined. That is a much more rapidly growing tumor. Okay, so the other thing I want you to think about is, all of the lesions, all of these bone tumors and tumor-like lesions have a zone of transition, including your more likely cancerous ones. So this permeative destruction that you can see here, where is that zone of transition? Can you even tell? Well, no, you really can't. It's so blended out. It's just, the thing is invading that entire bone, and that complete lack of zone of transition is just another sign that this is a faster growing lesion. And in addition, that because this has a permeative pattern without a zone of transition that we can really appreciate very well, then we know that this is rapidly growing and probably malignant. Okay, so then the next part of the appearance of this is, again, about the cortex and the periosteum. And this is going to be about what the lesion is doing to the cortex itself and possibly to the periosteum if it's involved. So if you take a look at this sort of quickly, you could see there are sort of three ways that the cortex and the periosteum are involved. You have a continuous, you have an interrupted, and then you have a complex. Now, the interrupted and the complex are obviously ones that are more likely to be malignant. So the continuous ones we would expect with non-malignant or benign tumors, but if the lesion is starting to push against the cortex, then you're going to have this, what's called a shell or expanded appearance. You might have what looks like lobes or lobulations, and then you might also have soap bubble appearance, which occurs with things like a giant cell tumor. And then, of course, with the interrupted, you might have like lamellated, which just means you have layers. So you can have a single lamellation, you can have multiple, and then as things get worse, you can start to have more interruptions in the patterns. You can have things like a buttress, which is the periosteum has lifted off and bone has filled it. You could have Codman's angle, where the lesion has lifted the periosteum off but has not deposited material underneath it. You could have lamellation, where the Codman's angle has multiple areas of where the periosteum has pulled away, maybe a little bit of bone deposition, it pulls away again, and some more, and then you can have, of course, the spiculated, which as you can see, it just looks like the periosteum is just coming right off of it. And then finally, you can have combinations of those things, which is what the complex is about. Now, obviously, the more benign this is, or the less cancerous this is, the more likely you're going to have a continuous type of cortical and periosteal involvement. But remember, benign doesn't necessarily mean aggressive. So you can have a benign or non-cancerous lesion that is locally aggressive, and we're going to see examples of that as we go. So here are some examples of these cortical involvements. So the first one would be, of course, none. There is no cortical involvement. That was the same image I showed you before, and that's a simple bone cyst, a very common lesion in the calcaneus, simple bone cyst. Now you could also have an expanded cortex, and that's that bottom left one. This is an expanded cortex. So you can see that the lesion has grown from inside the bone centrally. It's then pushed outwards, and the cortex is being significantly disrupted, and it's being pushed outwards away from it in almost like a centripetal pattern. So that's a giant cell tumor. Very commonly have this expanded cortex. So that is a locally aggressive lesion that will probably create symptoms. So what you're looking at actually is the proximal fibular head. And if you remember what's there, we have important anatomy. It's the common peroneal nerve. So as that thing pushes out, if it happens to push up against the common peroneal nerve, the patient might actually present to you with a foot drop. So that is a locally aggressive type of lesion. And you can see it has very, very thin cortical shell. That is a pretty fast-growing aggressive lesion. Now the next one there you can see with this cortical involvement is called endosteal resorption or scalloping. So if you remember what a scallop looks like, it has like little bumps in it, like so, like a seashell. And if you look at that, you can kind of see areas where the tumor is pushing up against the cortex, and as it pushes into the cortex, in different areas, you start to get some resorption of bone. That's where it's a lytic lesion, and you get some of those bump-looking types of things. And then finally, you can see that breakthrough cortex, and that's what I was talking about. If the lesion starts to invade even into the soft tissue, it breaks through the cortex. You can see on this axial CT scan, you can see the fibula has cortex that is interrupted, and the lesion has broken through that. So nice that they call it a breakthrough cortex. So those are your kind of 5 different ways that the cortex can be involved. And you can tell sort of how aggressive these lesions are just based on their appearance. So their appearance is really dictating, sort of what the histology and physiology is below it. So how about this? Ask yourself this question. What type of cortical involvement is this? You can see this first metatarsal has pretty much the entire first metatarsal is involved. And you have this large expansile lesion. So that cortical involvement is an expanded shell type of lesion. This happens to be a giant cell tumor. Okay. Here's another one. Here's another giant cell tumor. You can see that giant cell tumor for us is one that's very commonly expansile, has that expanded shell. Again, you can see the mostly well-defined lesion, pretty destructive, has that expansile appearance. And there's another descriptive term that's commonly used, and that is a soap bubble appearance. And you know what soap bubbles look like. So both of these lesions are tumors with a soap bubble appearance. So the giant cell tumor is in the calcaneus there. You can kind of see that there are sort of multiple lobulations to the sclerotic rim of that, and then similarly, but maybe less so on the tibial tumor that has a somewhat kind of bubbly appearance to it. So you have an expansile lesion that sort of creates multiple lobules, and then you get a soap bubble appearance. Let's move on to the periosteal reaction. So we talked about these different ones. So starting from the left and moving towards the right, you have your solid. You can see that that is a sclerotic lesion in the tibia. If you look down towards the bottom of the image closer to the ankle, you can see where the border of that is. So solid, there's no periosteum really reacting, so that's considered solid. And then the next one is lamellated. And if you look at where my red arrow is, you can see a single sort of longitudinal dark line that's in the cortex. And that is a lamellation, or a, lifting off of the periosteum. Of course, just to comment here, you can see that this has that this lesion where the yellow is pointing at is it shows it's not geographic destruction. It's really more of a combined permeative and moth-eaten appearance. The yellow line, the arrow is pointing at a moth-eaten area, but then if you look through the lesion, you really can't see where it ends again, and that's the permeation. Then, of course, there's that sunburst pattern that you can see, the sort of spiculation of the periosteum, and then the one on the far right is a Codman's angle. Some people call it a Codman's triangle, but I believe most people make a distinction to call this a Codman's angle, and it really depends upon whether or not there is bone filling in underneath the periosteum. You can call it whichever. I tend to call it Codman angle. Okay, here are a couple of other examples of periosteal reactions. And the one on the left is simply a fractured third metatarsal, and it has a bone callus around it. So that is benign. It's a solid periosteal reaction. You can see there's none of the other characteristics like spiculations or lamellations to it. It's pretty solid, and that is due to the excessive motion that's occurring at the third metatarsal. And then the other one, if you look carefully, you can see a fracture of the fibula. That is a pathological fracture. But if you look a little bit more distally, as you go down towards the growth plate of the fibula, you can see that there is a radiolucent lesion, and that the lesion has enlarged the bone a little bit. It has a little bit of an expanded shell cortex. So if you keep looking at that carefully, if you look very closely, you can see some lamellation to that. So some darker lines near the cortex region where you can see that the periosteum is starting to lift off of it. Okay. Now, the other part, the third part of this, is really about certain tumors, especially osseous ones and cartilaginous ones, will have a mineralization of the material inside the tumor. And one thing to keep in mind, if you haven't really thought about this, is that the tumor is typically not like a void of space and there's nothing in it. There is usually, in almost all of these, maybe a cystic lesion might have a little bit of just like clear fluid, but almost all of these tumors have material inside of them that you would need to take out if you were doing something with them. Okay, so if the central material is made of an osseous material, then it could look either solid, cloud-like, or ivory-like, and we'll see a couple of examples of these. Or it could be made out of cartilage, so it could be this stippled or flocculent or rings and arcs appearance. So let's get to some examples here. So here are three different bone-forming tumors. The first one on your far left is an osteoblastoma of the talar dome and portion of the neck. The talar head is normal. So this is a sclerotic bone-forming tumor of the talus. and you could see that it's solid. There's not a bunch of stuff there. It's just solid, kind of white. Um, then when you move to the middle one, we have unfortunately an osteosarcoma. That bone forming matrix is somewhat cloud like, and you can see that it's very poorly demarcated. You might describe it as a permeative pattern. That's absolutely fine. But you're remembering that because this is cloud-like, it's probably an osteosarcoma. It's a bone-forming tumor, and because it is not a geographic lesion, that it is probably something bad. And in this case, this was diagnosed as an osteosarcoma. And then the third one there, you can see it's another kind of stage of osteosarcoma, a later stage where the osteoblasts are replacing increasing amounts of bone, and you get this really white appearance, and that is this ivory-like appearance. So 3 kinds of bone forming or osteogenic matrices will tell you a lot about these tumors. The osteoblastoma, you'll recall, is a benign tumor, and it's really actually the same thing as an osteoid osteoma, except it's larger. So small is osteoid osteoma, large is osteoblastoma. Now, if we look at the cartilage forming matrix instead, you have to look really carefully on the left image. The 5th proximal phalanx has a lytic lesion, and this is an enchondroma. But if you look in the center of that lytic lesion, you'll see a small sclerotic area, little tiny kind of dots almost, and that is a stippled matrix. If you look in the middle one, this one is kind of a crazy example, but you can obviously see the tumor on the plantar aspect of the calcaneus. And this is considered a flocculent, it's much thicker, larger, more kind of put together lesion. And in this particular case, where the tumor matrix is coming off of the bottom of a bone or almost outside of it, this may also be called metallic in some cases. And then finally, the rings and arcs appearance, as you can see, is in this enchondroma on the right side. This is a proximal tibial enchondroma. You can see it's got kind of like little wavy lines and rings and curvatures of different shapes, and that is very typical for an enchondroma, and in some cases a bone island, which we'll see another example of shortly. Now, we mentioned osseous, and we mentioned chondroid or cartilaginous matrix, but you can also have a fibrous matrix, where these are literally fibroblasts that are working inside. And these will have what's called a ground glass appearance. Now, if you took a bunch of glass, ground it up into really small pieces, it would just be this kind of filmy, difficult to really make out material, and that's kind of why they call it a ground glass appearance. So here are 2 examples. The fibrous dysplasia, the lesion is in the proximal first metatarsal. You can see that sort of well-defined, it's a geographic lesion that's centrally located in the first metatarsal base. It has a bit of a sclerotic rim around it, and then its matrix, or its middle portion, is really this just kind of fuzzy material. There isn't anything specific to see. That's considered the ground glass appearance. And then the other one here is a chondromyxoid fibroma. This one, you can see, is much larger. It's more expansile. It's also centrally located, but it really envelops almost all of the metatarsal. And its matrix, again, is this sort of hazy, somewhat more sclerotic appearing area than the other one, but they're both considered ground glass appearance. Okay, now the next thing that we mentioned was was talking about the location. And in many cases, you're going to have lesions that are located in certain places. And unfortunately, this one's just a pure memorization. But in order to sort of give you some perspective, I want you to recall some of the terminology. So my orange square would be described, a lesion there would be described as centrally located. Whereas with the yellow, it's off to one side, so that's considered eccentric. If you have something involving the cortex, then it's the green box, and that's called cortical. And if something comes off of the side of the bone, outside of the cortex, but attached to it, that's called paraostial. So paraostial. If something was up against the inside of the cortex, and you have that, sort of pushing up against the cortex, in some cases that can be called endosteal. So remember that the periosteum is the outer layer of the cortex, not the periosteum, but the paraostial layer is the outer layer of the cortex, and the endosteum is the inner layer of the cortex. And of course, you already know that you can have the transverse location. The longitudinal location could be described as diaphyseal, metaphyseal, or epiphyseal. And in some cases, if something borders both the metaphysis and the diaphysis, it would be called metadiaphyseal. And less commonly, you could have something that's in the metaphysis and the epiphysis, and that might be described as epimetaphyseal in location. So here are a few different ones. These are some you've already seen already. If you look in the left image, you have multiple enchondromas or Alier's syndrome. And these are all centrally located, kind of in the middle. In this case, they happen to take up all of the transverse location of the bone, but they're not off to one side, so they're considered central. And then you have this unicameral or solitary bone cyst in the femoral neck. You can see it's pretty much in the middle. It's not just pushed off to one side. And then that same fibrous dysplasia that we looked at before was also centrally located. Here are some eccentric ones. So giant cell tumors are oftentimes eccentric, and that's the one that you can see in the talar dome. You also have an osteosarcoma that is eccentric in the kind of opposite location. It is not centrally located, so it's eccentric. And then this chondromyxoid fibroma in the calcaneus, it's in the kind of posterior body of the calcaneus, is sort of pushed off to one side as opposed to being in the center of the calcaneus, and that's considered eccentric. And then there are the cortical ones. So you can see that non-ossifying fibroma on the left has that. Remember, that was the one with the scalloped appearance. As you can see that it is not just eccentric, not just pushed to the side, but it's actually into the cortical bone itself. So it's involving that. So that's cortical. Some people might argue with you and say that is just eccentrically located. But easier for you to see is this osteoid osteoma in the proximal phalanx of the hallux. And you can see that that's really just involving the cortex of the bone and starts to push out a little bit. So that's considered cortical. And then finally, paraostial. And you can see that osteochondroma we looked at before coming off of the external sort of cortex of the calcaneus. That's paraostial. And then, unfortunately for this person, on the left side, they have a paraostial osteosarcoma. And, osteosarcomas can be, oftentimes can be named by their location. So you can have a central osteosarcoma or a paraostial osteosarcoma, and they behave in different ways. So you could see that tumor, that mass of sclerotic bone, is coming off of the cortex, and it doesn't appear to be involving the medullary cavity at all. So these have better prognoses, actually. Okay, now if you like to memorize images or if you like pictures, you can see that in the epiphysis, metaphysis, and diaphysis, you have various tumors. The one I want to point out to you, though, is the giant cell tumor. Um, if you look in the bottom sort of right corner of this image, you can see where it says child is metaphyseal and adult is the end of the bone. And that's actually a really common finding. And one way that you will see as you look through this that giant cell tumors abut the joint but don't necessarily destroy it. The tumor comes right up to it. Very common. Now, you can see there are transverse locations. There's central. There's eccentric or um, there's paraostial, there's involvement of the cortex itself. They're all different locations, and this is a good sort of overall summary of this. Okay, so there are a few tumors that are commonly found in specific areas of the foot, or they have predilection for certain areas. So let's start from the left. The fibrocortical defect typically is involved in the distal tibial metaphysis, as you can see there. While the intraosseous lipoma and the simple bone cyst or unicameral bone cyst are usually calcaneal. The osteosarcoma is talar neck and calcaneus, and the enchondroma is really common in toes and sometimes in metatarsals. But if you see a lesion, a lytic central, maybe somewhat expansile lesion with a sort of flocculent or rings and arcs kind of appearance, that might be an enchondroma of the phalanx. Okay, one last comment about all these different characteristics. Now, you're going to make presumed diagnoses for a lot of these, and you're going to think about how aggressive it is it benign versus malignant, what about the age of the patient, but really you're going to get imaging, and then you're going to get advanced imaging. So, you're going to have a patient who's going to have a complaint of some sort, swelling, pain, maybe some functional problem as a result of a lesion. You get an x-ray because it's very common to do that. And when you see that, you're then going to, in most of the cases, you're going to get advanced imaging, CT scan, MRI, as you can see in this image. This is a T2 weighted MRI. Those are most commonly ones that you might get. But in some cases, specialists might get PET scans or bone scans, depending on what they're looking for. You can definitely see that you can get some more information from the MRI than you can from the X-ray. In this particular case, you can see that the lesion is filled with fluid, and that fluid is blood. So this is an aneurysmal bone cyst, and you can see the other details that we had talked about, but the fact that it is fluid filled gives you a further information, so at least you know what to expect when you approach this lesion. Here's an example of a patient of mine. I happened to see this patient for plantar heel pain, and she had no ankle involvement at all, but you can see this is actually an enchondroma, probably an enchondroma, maybe something called an anastosis or a bone island. And how would you describe this? So think about that for just a second. If you were asked to describe this lesion, think about it in terms of a pretty systematic approach. This is a geographic, well-defined lesion that is mostly sclerotic, but has a somewhat chondroid appearance. It is very well defined. I think I mentioned it's centrally located. You can see that it's in a skeletally mature adult. So this is, since I told you it's an enchondroma already, we know it's not a child. And this was totally symptomatic. It was just a random finding that happened to come up, and the other side did not have this at all. So this is called a no-touch lesion, actually, because if you biopsy this, in some cases, it could actually look like a malignancy or something more aggressive, and then the patient ends up having a whole bunch of testing, and maybe oncology is involved, and then they go in and try to remove the lesion, and that was never necessary in the first place. Okay, how about this one? Can you describe this and maybe think about what it is? So I would say this is a geographic, well-defined lytic lesion that is hard to tell if it looks centrally located. It has a breakout cortex, as you can see on the sort of more, I guess that's the more lateral side. This is a hand. This lesion is epiphyseal and metaphyseal in location. And so this is probably a giant cell tumor because of that sort of description. We can see that this patient is probably skeletally mature. So that means they are older than 20. And so giant cell tumor is probably our most likely one. Okay, so that pretty much covers it. You made it through PMP4. You managed to do it in breakneck speed. This 16-week class you did in 10 weeks. My gosh, that's crazy. We're going to be covering a lot of these things during your third year in a variety of different places. So you've done a great job. I hope you enjoyed the class for as much as that is possible during this whole COVID nonsense. Hopefully, as you get into your clinical rotations, you'll really get to start to pull in all of the things that you've learned and really start to bring together all those skills. Remember that what you know is going to make you a better doctor. So don't forget these things. Make sure you have some way to access this material when it invariably will leave your head. And I will wish you good luck on the rest of your semester. I hope your final exam goes well, and I'm truly looking forward to working with you in clinic. I'll see you soon.